Hello everybody. Today we're going to be discussing this paper that was published by the PI-RADS Steering Committee on the MRI biopsy pathway. It certainly has attracted a little bit of interest in Twitter, and you can see a number of high engagement rate. Three key messages from this paper. Message number one, high quality PI-RADS compliant MRI should be performed before biopsy in most men suspected of having clinically significant disease who are likely to be offered active treatments. Message number two, a safety net of monitoring must be in place for patients who decline immediate biopsy after a low likelihood MRI, and this should include clinical, laboratory, and imaging investigations as per local clinical practice. Message number three, for men who have positive scans, that is to say PI-RADS category 3 to 5 scans, combined systematic and targeted biopsies should be performed in biopsy-naive men. However, only targeted biopsies are needed for men who have had previous negative findings on a systematic truss biopsy. These messages reflect the recommendations of the 2019 EAU guidelines. And this comes on the back of a number of high evidence level prospective clinical studies, including the Precision trial, the MRI First study, and the 4M study, and now multiple consistent systematic reviews and meta-analyses, including the very influential Cochrane review, which was also published in 2019. The Cochrane review is summarized on this slide. If you compare a systematic biopsy pathway where everybody gets a systematic biopsy compared to an MRI pathway where negative men get no biopsy and positive men only get a MRI-directed biopsy, the Cochrane review found that about 1/3 of men can avoid a biopsy completely, and there's a statistically significant reduction in overdiagnoses. You can see that the detection of clinically significant disease, whether you define it as ISUP equal or greater than 2 or equal or greater than 3, is only marginally increased. So the major benefit appears to be in biopsy avoidance and lowering the detection of clinically insignificant disease. What this means in clinical practice is that MRI is 12% more likely to make a correct diagnosis using fewer biopsies in a mixed outpatient practice. So if you had a prevalence of 30% of clinically significant disease in your practice, if you use systematic biopsies alone, you would miss 111, and about 1/5 of these would be ISUP greater than 3. On the other hand, if you use the MRI approach, which we've just said is no biopsies for negative men and only targeted biopsies for positive men, you would miss much fewer, 84 compared to 111, and the ones you did miss, the majority would be microfocal ISUP2s, very few ISUP3s. So you make more correct diagnoses using the MRI pathway. Of the 700 men that do not have clinically significant disease, you can see that on systematic biopsy, all 700 men would have to undergo a biopsy so that they could be correctly identified. However, on the MRI side, only 28 men would need to undergo a biopsy to confirm the absence of clinically significant disease. So you can see the impact of MRI not only in making a correct diagnosis in a mixed outpatient practice, but also doing fewer biopsies overall. And so these are the benefits of the MRI pathway. The pathway is shown on the right-hand side. You can see that subjects at risk of clinically significant cancers are often pre-stratified using clinical tools, including PSA, digital rectal examination, and sometimes risk calculators. Those men who are deemed not to be at sufficiently high risk return back to their GPs. If they are considered to be sufficiently high risk, they undergo a PI-RADS compliant MRI, and if this is negative, provided that there are no high risk factors, they don't get an immediate biopsy, they return back via an MDT to their general practitioners. If they are positive or they are negative but have high underlying risk factors, such as a PSA density or risk stratification score or genetic history, they can undergo 1 to 2 biopsies, and if negative after biopsies, then they may return after a discussion to urological care. On the other hand, if they are positive, they undergo a risk stratified therapy. And the claims for this pathway are shown on the left-hand side of this slide, which shows, as we've discussed, reduced numbers of patients undergoing biopsy, reduced diagnosis of indolent cancers, increased detection of disease in prior negative biopsy men, and a greater precision of volume determinations for most patients. However, we have to acknowledge that the PI-RADS system is not perfect. So, for example, we know that up to 50% of men with positive MRIs who do undergo a biopsy have either negative histology or have only insignificant cancers detected. We now estimate that between 30 to 50% of men who get gadolinium contrast injections don't benefit from the injection. We've now beginning to realize that the performance of radiologists in clinical practice don't match those seen in higher volume centers. And this is because there's a steep learning curve for MRI interpretation and also, of course, for biopsy performance. And there is a level of expertise that needs to be arrived at to deliver the benefits that we've talked about. MRI, of course, is also time intensive, not only to review and report, but if radiologists are going to contour MRI lesions prior to MRI biopsy, that again will take time. One of the biggest issues that we have is that there are multiple quality issues for MRI acquisition, interpretation, and of course for the biopsy process. So how do we begin to deliver the promise of the MRI pathway so the benefits become available to all? There are a number of things that we need to think about. A major consideration is what to do with the MRI results. If the aim is to maximize the yields of clinically significant cancer, the so-called combined biopsy pathway needs to be employed, where negative patients undergo a systematic biopsy and patients with positive scans undergo both systematic and MRI-directed biopsies. This is the preferred route by many urologists. If the aim is to minimize the diagnosis of insignificant cancers, then men with negative scans should not go undergo a biopsy, and men with positive scans should only undergo an MRI-directed biopsies without systematic course. Of course, there is a middle ground where men with positive scans undergo both a targeted biopsy as well as a systematic biopsy. The decision is very much dependent on the prevalence of disease in patients with negative scans and in those with positive scans. So let's discuss this next, starting off with men with negative scans. By definition, men with negative MRI scans are at lower risk of having clinically significant cancers. If you took 100 men with negative MRI scans and you exposed them to systematic biopsies, 74% would be found to be negative. 18 men would be overdiagnosed with clinically significant cancers, but 8 men would be found to have clinically significant cancers and therefore would receive an appropriate treatment. In other words, to detect 1 man with clinically significant cancers, 12 to 13 men would need to be biopsied, but for every man detected with clinically significant disease, 2.5 men with insignificant disease would also be detected. Not doing a systematic biopsy after a negative scan would mean that we would miss 8 men with clinically significant cancers. And 3 of these men would have a high-grade ISUP3 or greater tumor. So what do we do to minimize treatment delays for these missed cancers? A robust safety net of monitoring clearly needs to be in place. We know that the majority of emerging clinically significant cancers will be found within the first couple of years, and a safety net monitoring regimen will be able to find these. Here's a couple of examples from the 4M study and the NICE guidelines regarding what a safety net monitoring regimen might look like. So if you look at the NICE guidelines, it recommends discharging patients to primary care if the suspicion level is low after a negative MRI scan. GPs are advised to perform PSA levels at 6 months and then every year thereafter, and then to re-refer based on a rising PSA density or a rising PSA velocity. And this is what the PI-RADS committee recommends. For men with negative scans, a systematic biopsy should only be performed if patients are at high risk after a negative scan. And if they are not at high risk, no immediate biopsy should be performed, and a safety net monitoring regimen should be set up according to local priorities. And the EAU guidelines also recommend the same course of action. In biopsy-naive men, when the MRI is negative and clinical suspicion is low, omit a biopsy based on shared decision-making. When an MRI is negative and clinical suspicion is high, perform a systematic biopsy, again based on shared decision-making. Another area where there's quite a lot of controversy is what to do with men who have positive MRIs. In other words, they have intermediate or high risk after performing an MRI. The debate is about whether to perform fusion biopsies alone, whether we perform targeted biopsy cores with focal saturation, or targeted biopsies with systematic cores. This data from the 4M study underlines the essential issue. You can see that in PI-RADS 4 cases, if you perform systematic biopsies, you get an increased yield of clinically significant cancers, and this also applies for PI-RADS 5 cases. So what should you do with positive PI-RADS results? In the combined biopsy pathway, where the aim is to maximize clinically significant disease detection, the addition of MRI targeted biopsies to the systematic biopsy increases biopsy yields considerably. Here you can see 10%. In the MRI biopsy pathway, the idea is to minimize the detection of insignificant disease, so only positive men undergo biopsy. If you were to add a systematic biopsy to these men, the increase in yield will in fact be 5%. And this is sometimes called the augmented pathway, where the systematic biopsies are added, so compromising on overdiagnosis. So let's imagine 100 men with positive MRI scans who undergo both MRI-directed biopsy as well as systematic biopsies. In 35 of these men, you will not find cancers. So these 35 men will have undergone a double procedure with a greater exposure to additional biopsy side effects. 21 men will be diagnosed with insignificant cancers, being overdiagnosed and now being exposed to the costs of active surveillance. However, 44 men are significant cancer diagnosed and have appropriate treatment. If you did not perform the systematic biopsy, 5 men with insignificant cancers would have been misclassified. And so these are the ones that would have been missed if you didn't perform the systematic biopsy. We clearly need to balance the harms and the benefits of the combined biopsy, because we want to decrease the overdiagnosis of insignificant cancers, but we do not want to reduce the underdiagnoses of clinically significant cancers if we perform targeted biopsies alone. How can we do this? Well, multiple studies show that the absence of clinically significant cancers after targeted biopsies are in fact due to targeting errors. And this is nicely shown by the Cochrane review, where if you look at the number of men who are positively diagnosed with clinically significant cancers on an MRI, but verified by a template biopsies, is quite high. The sensitivity is about 90%. However, once you start doing targeted biopsy cores, you can see how the sensitivity drops, but the specificity increases. So the answer is clearly to do more biopsies, thus increasing the detection of clinically significant cancers. The real question is, can we do a smarter targeted biopsy to try to recover some of this performance? If we look at the data, clinically significant cancers are often in sextants adjacent to the MRI targets. And we know that systematic sampling of normal appearing areas in non-adjacent sectors does not alter the risk stratification in the majority of patients. We've now come to learn that focal saturation around an MRI detected target increases clinically significant detection rates without greatly affecting overdiagnosis rates. So if you look at this paper recently published, you can see that performing more biopsy cores around an MRI defined target increases the detection of clinically insignificant disease, impairing just a little bit the detection of insignificant cancers. So maybe this is the way to go. However, the optimal number and the framing of biopsy cores per MRI lesion is currently unknown. And it may be that we have to use fewer cores for larger lesions and more cores for diffuse heterogeneous lesions, smaller lesions, or perhaps PI-RADS 3 lesions. The EAU guidelines, in fact, suggest that when an MRI is positive, combined and systematic biopsies should be performed for biopsy-naive men, but in those patients who have had prior negative biopsies, only a targeted biopsy needs to be performed. The PI-RADS committee in general agrees with this recommendation, so the recommendation is to perform MR-targeted biopsies and systematic biopsies, but you can see how the PI-RADS committee leaves open the option of performing focal saturation biopsies for biopsy-naive men. The next thing we need to think about is what we do with indeterminate PI-RADS 3 cases. We know that there is a higher prevalence of PI-RADS 3 or indeterminate scans when inexperienced readers read scans or when the biparametric MRI approach is used. Even in the most experienced of centers, you can see that the PI-RADS 3 cases increases as you withdraw the number of imaging planes and withdraw gadolinium injections. We know that within PI-RADS version 2.1 that the number of PI-RADS 3 cases will increase within the transition zone. There is also a high but variable prevalence of significant disease within the PI-RADS 3 category, and currently there is no agreed way of separating higher and lower risk PI-RADS 3 cases. As a result, all cases get called positive and therefore need a biopsy. So how often do we see PI-RADS 3 cases? The overall prevalence within the literature is about 15 to 16%. Interestingly, the prevalence of clinically significant disease within this category is also about 18%. So a figure to keep in your mind is that the prevalence of clinically significant disease on average is between 15 to 20%, i.e. 1 in 5, and 1 in 5 of these men will have clinically significant cancers. So what do we do about these indeterminate cases? The first thing we can do is perform an expert peer review. Secondary reading can certainly be very helpful, and secondary reading should check if gadolinium contrast was administered. So here's a PI-RADS 3 lesion in the peripheral zone. If you look at the ADC map, you can see there's a focal area of decreased signal intensity in the left side of the peripheral zone, which may be slightly hyperintense on the high p-value image. Difficult to see, but if you looked at the calculated ultra high p-value at 1500, this suddenly is very suspicious that in fact there is a PI-RADS 4 lesion underlying this. However, it's quite easy to see that on contrast enhancement that this indeed is a PI-RADS 4 lesion. So the addition of contrast in this particular instance converts a PI-RADS 3 to a PI-RADS 4. Besides checking the quality of scans, an MDT review can also be very helpful when evaluating patients, taking into account the clinical history and the patient's priorities. Here, for example, is a 30-year-old man with what looks like inflammatory disease. This patient's priority is not to overdiagnose clinically significant cancers. The history clearly indicates infection, and although this is a PI-RADS 3 case, this patient does not require any biopsy. The PSA density can also be very helpful when trying to make biopsy treatment decisions in PI-RADS 3 categories, and this is shown by the data from the 4M study on the left and the BIDOC study on the right. You can see that a PSA density of greater than 0.15 increases the yields of clinically significant disease for higher PSA densities. The value of a central review is confirmed by this study, which showed that an expert radiological urological review does help to decrease the number of PI-RADS 3 and 4 cases, converting them into normal cases, and also changes the need for and the type of biopsies undertaken in patients who are positive. The last area I'd like to discuss is how we minimize variations in MRI reporting and biopsy rates. There clearly is a need to certify readers, biopsy operators, and accredit diagnostic units. We need to do this because the major benefits of MRI derive from reducing harms by decreasing number of biopsies and by reducing the number of indolent cancer detected. We know that experts have a higher normal call rate and lower indeterminate cases rates, and we know that experts can enable the adoption of the biparametric approach, therefore reducing costs. By minimizing variations within the PI-RADS categories, we can be much more certain of the likely prevalence of disease within these categories. And it is important to have a uniform, reliable quality for patient decision making. And this would increase confidence not only for patients but also for payers. We know that there's considerable variations between different studies in the rates of normal, intermediate, and positive scans. So if you looked, for example, at first biopsy studies, look at the variation between the studies of what was called normal. Look at the variation of what was called indeterminate, and look at the variation that we see between studies in what's called abnormal. Even within a given study, we see considerable variation between different readers for the different PI-RADS categories. So we've got variations between studies, we've got variations within studies for different reporters. We also have variations of the rates of clinically significant cancers within different PI-RADS categories. So if you look at PI-RADS category 3, we know on average it's about 12%, but if you look at the confidence interval, you can see it's from 4 to 14%. If we look at ISUP 2 cancers in PI-RADS 4 categories, on average it's about 30%, but it varies anywhere between 15 and 45%. So a huge variation even within different PI-RADS categories. To minimize variations, we need to think about accreditation of prostate cancer diagnostic units and certification of radiologists or urologists who interpret MRI scans and perform biopsies. Thinking about radiologists initially, training and mentoring and the learning curve are some things that we need to consider. The minimal number of reports per year that are being performed, benchmarking of positive cases, MDT participation, and audits need to be considered. The PI-RADS committee makes no specific recommendations on certification of radiologists and instead encourages local efforts which may be countrywide or region-wide, noting what's recently happened in Germany. Okay, so let's conclude. MRI can identify the 30% of men who can avoid biopsy after negative scans. MRI therefore reduces the detection of clinically insignificant disease. We can increase the detection of clinically significant cancers, particularly in prior negative biopsy men, and likely in first biopsy situations also. MRI-directed biopsies do have a missed error rate, which reduces if you perform more targeted biopsy cores. MRI and MRI-directed biopsies can work if we accept that we will not find all clinically significant cancers immediately, and therefore we need robust safety nets for negative men and for positive cases who have negative biopsies. Using biomarkers such as PSA density for patient selection and biopsy decision making can be very helpful. We need to assure the end-to-end quality of the entire diagnostic chain with multidisciplinary working. Thank you for listening. I hope you've enjoyed the video. Please read this accompanying article, which is freely available. If you have any comments, leave them for me. Thank you very much. Bye-bye.